Good morning, everyone. Today, I will be discussing an important and clinically relevant topic: why winter and cold exposure significantly increase the risk of acute myocardial infarction and causing more mortality. Seasonal variation in cardiovascular events is well documented with a consistent rise in acute coronary syndromes during winter months across geographical regions. In this talk, I will explain the pathological mechanisms by which cold exposure act as a cardiovascular stressors, precipitating plaque rupture thrombosis and myocardial ischemia, particularly in vulnerable populations. This discussion is intended for medical professionals, and we will focus on mechanistic insights, clinical triggers, and implications for practice. Seasonal epidemiology of myocardial infarction. Large population studies demonstrate higher incidence of STEMI, ST elevation myocardial infarction, and non-STEMI in winter. Increased early morning MI events are very high in winter. Higher short-term mortality during cold spells. Even modest reduction in ambient temperature are associated with measurable increase in MI risk, suggesting that cold exposure itself rather than behavioral factors alone is a major trigger. Let us see what's happening in thermoregulatory vasoconstriction and hemodynamic load. Cold exposure activates thermoregulatory mechanisms aimed at preserving core body temperature. This is mediated by primarily through sympathetic nervous system activation, alpha adrenergic vasoconstriction. The physiological consequences include increased systemic vascular resistance, elevated systolic and diastolic pressure, increased left ventricular afterload. From a cardiac standpoint, this leads to increased myocardial oxygen demand, reduced coronary perfusion pressure, discharge to fixed stenosis. In patients with established coronary artery disease, this supply and demand mismatch can precipitate ischemia and contribute to type 2 myocardial infarction or act as a trigger for a plaque rupture. Sympathetic overactivation and autonomic imbalance is a very important factor. Cold stress results in sustained sympathoadrenal activation. This leads to elevated circulating catecholamines, increased heart rate and blood pressure variability. Reduced heart rate variability. Clinically, this autonomic imbalance increases myocardial oxygen consumption, promotes coronary vasoconstriction and vasospasm, increases susceptibility to ventricular arrhythmias during ischemia. This mechanism is particularly relevant in smokers, patient with the endothelial dysfunction, patient with variant or microvascular angina. Cold is a hypercoagulable state in winter. Winter months are associated with a prothrombotic hematologic profile. Observed changes include increased platelet counts and platelet aggregability. Platelet aggregation will be very high in winter. Elevated plasma fibrinogen levels. Increased factor 7 and factor 5. Increased blood viscosity due to hemoconcentration. These changes collectively enhance thrombus formation at sites of plaque disruption, increase the likelihood of occlusive coronary thrombosis. This explains the higher proportion of ST elevation myocardial infarctions observed during colder months. Endothelial dysfunction and plaque instability is a main reason for acute coronary syndrome. Cold exposure adversely affects endothelial function. Mechanisms include reduced nitric oxide bioavailability, increased oxidative stress, heightened inflammatory signaling, seasonal increase in C-reactive protein, interleukin 6, and other inflammatory mediators promote endothelial activation, increased shear stress at plaque shoulders, destabilization of thin cap fibroatheromas. This environment favors type 1 myocardial infarction due to plaque rupture and thrombosis. And another circadian blood pressure variability happens in winter. The winter is associated with blood pressure variation in higher 24 hours mean blood pressure. It will be exaggerated morning blood pressure surge, increased prevalence of non-dipping or reverse dipping patterns in hypertension. These hemodynamic changes coincide with peak sympathetic activity, increased mechanical stress on coronary plaque, explain the higher incidence of early morning myocardial infarction. This is especially relevant in patients with uncontrolled hypertension, early morning myocardial infarction, chronic kidney disease, autonomic dysfunction. What happens when you expose it to cold, the sudden exertion, if you do strenuous activity or like jogging or running and doing any like a heavy activity in winter? Acute accustomed physical exertion in cold conditions represents a classic trigger for myocardial infarction. Examples: snow shoveling, heavy lifting, sudden brisk walking in cold air. Pathophysiologically, this results in abrupt rise in heart rate and blood pressures. Increased catecholamine release, marked increase in coronary shear stress. This combination is particularly potent in triggering plaque rupture in susceptible individuals. What about the respiratory infection and systemic inflation? How it is going to affect heart? The winter is associated with the increased incidence of influenza, pneumonia, and viral respiratory infections. These infections contribute to myocardial infarction through systemic inflammatory activation, endothelial dysfunction, procoagulant state, fever-induced tachycardia, and increased oxygen demand. Both type 1 and type 2 myocardial infections may be precipitated in these settings. The people, those who are very vulnerable and comes under high risk in winter. The winter-related increase in MI is almost pronounced in elderly patients. Diabetes with autonomic neuropathy, patients with chronic kidney failure, chronic kidney disease, those who are undergoing dialysis, heart failure patients, stage 3 and stage 4 heart failure patients, those who are on device and on congestive treatment, patients with the multivessel MI and multivessel CAD. Socioeconomic factors such as inadequate heating and delayed healthcare access further amplify the risk. The chemical implications and conclusions. Winter acts as a multifactorial cardiovascular stress test. Cold exposure simultaneously increases afterload, activates the sympathetic nervous system, promotes hypercoagulability, impairs endothelial functions, triggers plaque instability. In high-risk patients, this convergence converts stable coronary artery disease into acute coronary syndrome. From a clinical standpoint, winter should prompt aggressive risk factor optimization, reinforcement of medication adherence, blood pressure monitoring, counseling against cold exposure and sudden exertion. Early evaluation of atypical ischemic symptoms. Understanding these mechanisms allows us to anticipate the risk and educate the patients and prevent avoidable myocardial